Hi, Doc. So we are live now, and we'll wait a bit for some people to join in, and then we start.
Okay.
Yes. Okay, so we have two people that have joined in, so we are going to start now. So let's wait. Great. Thanks very much. Good morning, good afternoon, good evening, wherever you are watching us from. My name is Anita Samoa, as you know, and today I have with me a very what adjective should I use? But you let me just say I have a specialist. He's a physician anesthesiologist. You know, this category of people, they are very, very important in the theater. Without them, probably there wouldn't be anything like operation or surgery or whatever. They are, should I say, the backbone in the theater, because if they can't make you go numb in some certain areas or go asleep, the doctor wouldn't be able to perform the surgery or whatever procedure he or she has to do. And so the anesthesiologists are very important. But today, we are trying to look at the myth and facts people have about cesarean section, especially our women. And it's not just our women. It starts from even mother-in-laws. Some mother-in-laws don't even want their daughter-in-laws to undergo cesarean section, or what we say C-section. They feel that when you undergo a C-section, you are never going to be the same, and that your subsequent births won't, you would be through CS, and they always want to try as much as possible to avoid the first birth being through CS. So today, doctor is going to, we are having a general conversation. Doctor is going to tell us more on. Already we have some questions on Facebook, which I will read out when we start. So first of all, doctor is going to introduce himself, and then we begin. Dr. Osei, thank you so much for being here with me, for doing this with me this morning. So over to you.
Okay. Thank you very much, Nita, for that lovely introduction there. So morning, afternoon, or evening, wherever you are. So my name is Dr. Osei. I'm a senior specialist anesthesiologist at Korle-Bu Teaching Hospital. So we use the terms anesthesiologist and then anesthetist. Anesthesiologist is a bit of a mouthful. So sometimes you hear people saying anesthetist. And the anesthetist is actually the term that the British or the UK started using in terms of somebody who administers anesthesia, whilst the Americans termed it as an anesthesiologist. And the term is they use, I think right now it's much more commonly to say anesthesiologist. But in Ghana, there are problems with R's and L's and S's and stuff. So some people get confused and they don't want to say that anesthesiologist itself. Even me myself, I find it a bit tricky to say.
Difficult.
So what is an anesthesiologist? What do we do? I think it's good that we have this platform and that we can have a chat so that everyone knows exactly what do anesthetists do. Because I think it's sometimes people get confused and they're like, what's the role of these people? And I on my Facebook page sometimes talk about what we do, and I'm sure people have always been curious as well. So I'll tell you what, back in the day, when surgeons used to operate, our body, we have protective systems. As soon as you touch us, you will feel it. If someone cuts you, you will feel it. Now, back in the day, they always wanted to know how could they perform these surgeries much more easier than just cutting people. I'm sure that you've watched these old movies and you see them traditional times. If they're coming to cut someone or coming to move something, then they'll try and do something so that they can numb the pain. So either you drink some alcohol, or you see they try and take your mind off it, or by putting some wood into your mouth. Those kind of things, because all the things where your body has protective mechanisms against any form of injury, and that is always reflected as pain. So it's always been a goal to try and find out how can surgeries be performed without patients feeling pain. Now, as an anesthesiologist, my role is to make sure that a patient that's coming for surgery does not feel any pain. So that was the initial role of an anesthesiologist. And so what people know was about anesthesiologists coming and it will give you a gas, and then you fall asleep, and then you do the operation. So that was it, the initial role of anesthetist, I'll say anesthetist, back in the day. But then as the specialty progressed, and then people saw that it was a unique specialty, then we started moving into other areas. Areas such as care of critically ill patients. Those are patients that are in intensive care units. And this was actually brought to light in terms of what happened with COVID-19. We saw what happened with COVID-19, that people were afflicted with this terrible virus, and those who had severe symptoms found it very difficult to breathe. So they actually had to be admitted at intensive care units where they were actually ventilated by machines. So there's a machine that was actually doing all the breathing for the patients, and then they had to be taken care of. And this was done by the anesthesiologist, because we are involved in terms of critical care. Yeah. So when you see all the news reports that they had about anesthetists, about the patients that were being cared for, and saw them in the critical care, those patients were being taken care of by anesthesiologists. So we are involved in terms of our intensive care, intensive care. And then also we've also branched into terms of training of people for cardiopulmonary resuscitation, which we commonly call CPR. You know that sometimes somebody can have a sudden cardiac arrest, their heart stops beating. Yes, and then you have to start taking care of the airway, breathing exercise, all those compressions that you sometimes see them doing in movies and stuff. It's anesthesiologists who are involved in that kind of training as well. And then also in terms of pain services, it's not everybody who is coming for operation who is in pain. Sometimes there are people who have pain, chronic pain. That's like, it's not something that comes and goes. It's something that's there and it's always there consistently. So sometimes these people have chronic pain in the back, they may be having pain in the thigh. So they need to see an anesthesiologist who will come and take care of that pain. And we do things like not just simple giving medicines. We do things like blocking of specific nerves, trying to find out about where this pain is coming from, and trying to make life much more comfortable for the patient. So anesthesiology, we do so many things, but the things that people know us most commonly for is about putting you to sleep for the operation. And even about putting you to sleep, it's not always that we're always going to put you to sleep. It's not always that we have to put you to sleep. So that's just a general overview of anesthesia. Yeah. So today we're going to talk about anesthesia and cesarean section.
Yes.
First thing I'd just like to say is that in terms of anesthesia, there are 3 different ways that we can do it.
Okay.
We can put your whole body to sleep. That's what's called general anesthesia. Then we have regional anesthesia, where it's only a part of your body which is actually anesthetized, which is actually numb. Okay. And then we have local anesthesia, where just a specific region is numbed. So there are 3 different types of anesthesia. The ones that we are commonly involved with will be your general anesthesia, which I've talked about, which is the whole body being anesthetized. And then we have your regional anesthesia, which is parts of the body being anesthetized. Sometimes there's operations that you do where it's not, you don't have to put all the numb the whole body. For instance, if you're working on somebody's leg, then there's no need that you need to put the patient to sleep. So we have techniques which we can do, which we can specifically numb that leg to be worked on. And this is very useful in people who have got a broken leg where they need to work on.
Okay.
It's the same thing for someone who's coming for a cesarean section, which is for delivery of a child. We don't need to put you all to sleep. We just need to concentrate on the lower part of your body, that's below your pelvic button. Or sometimes even for fibroid operations or people who are having their womb removed. So that one we do what we call regional anesthesia. And it's the most common thing we do, especially when we're dealing with surgeries of below the belly button. But sometimes we have to put the whole body to sleep, yeah. But all of this depends on different circumstances. Every patient is different, and there's different circumstances. So that's anesthesia in a nutshell. And as I said, we have, when we're concentrating on this, we have general, we have regional, and then we have local. But well, in simple terms, as I say to a layman, the job of an anesthesia and the anesthesiologist is that he should make sure that the patient is comfortable so that the surgeon can do his operation, and then afterwards the patient is fine and is taken back to the ward.
So from what you are saying, yours is from when the patient is booked for surgery. So you okay, I know they run tests for you to see and all that. You know how the patient is, and I know they do all that. But do you sometimes see the patient one-on-one yourself before the surgery? Like, I'm coming for a CS. You are going to be the anesthetic guy there. The doctor has booked me. I've seen my doctor. Do you sometimes, do I need to meet you so that I develop a rapport with you before the day?
So I forgot to say, in terms of surgery, there are two kinds of surgeries that we have. We have what we call elective surgeries. These are surgeries that are planned. And then we have emergency surgeries, which are surgeries which are not planned. Now, with elective surgeries, these are planned. You may have been seeing your obstetrician and he decides that, you know what, Anita, because of your condition, I think we're going to have to operate on you. So in 2 weeks' time, we'll book you for this surgery. So what happens is that he will request some labs for you. We'll check your blood just to make sure that things are fine. Let's check your sugars. Let's check your kidneys. Are your kidneys working okay? Those things will be checked and then seen. Then we have what we call an anesthesia clinic. So this is a clinic which is run at the hospital. And patients go there before surgery. You go there, you see an anesthesiologist, you talk with the anesthesiologist who will ask you some questions. We want to ask some basically because we want to know more about you. So we'll ask, have you had an operation before? Sometimes we want to know what condition do you have. Sometimes it's not just the operation. Sometimes there's some people who have some conditions too. They have high blood pressure. They may be asthmatic. Sometimes we also want to know about the operation you've had before, because sometimes some people, they've had anesthesia, they may have had a bad experience, it may not have been good, some things may have happened. This will give us all little clues about you and how we should handle you. So this happens at the anesthesia clinic. Then we ask some few questions. We also give the examination. We want to check how you are. Are you well? Are you looking unwell? Are you pale? Is your eyes yellow? Then we also want to look at your mouth too, because your mouth, very, very important for us. It's called the airway. We're interested in your mouth because your mouth is this is where we are going to be concentrated on. Now, as I said, sometimes we have to give anesthesia. When we're giving general anesthesia, we may have to put a tube down your mouth. And that tube down your mouth is going straight through your larynx into your lungs, because we will be breathing for you during the operation. And this is something that happens during general anesthesia. So because of that, we want to know about your mouth. If there's any problem there, we need to do anything about it. Sometimes some people have some very small mouth. Sometimes some people have big mouth. You can't pick it. Sometimes you may have a very short neck. Sometimes you may be big, obese. All of these things will give us indications that
they can't.
But it's just for us to get to know you. Yeah. And then at the anesthesia clinic too, the other thing which people forget, but they actually have the right to, that you can ask about the anesthesia you're going to get, because we'll talk to you about it. Sometimes some people want to know, are you going to give me gas? I'm going to sleep, or is it just part of my body? No, sometimes some patients have some concerns. And then the other thing that sometimes happens too is that patients want to know about the surgery itself, because they may not have had that information from the surgeon when the surgeon was booking them for. It happens a lot because, because of our culture and because we're scared of doctors, people are afraid to ask questions. But actually, when the surgeon was booking for operation, you have every right to ask the surgeon, what are you coming to do for me? And things are changing. Back in the day, you'd be afraid for a patient to ask the doctor what he's coming to do for you. It's as if like your integrity or your competence is being
questioned.
But there's nothing wrong with that at all. You can ask. No, there's nothing wrong with asking questions. So this happens at the clinic. So sometimes there. But what you need to know is that at the clinic, when you see the doctor there, that's not necessarily the doctor that's going to provide the anesthesia or your surgery. Because we have so many different theaters running, and as anesthetists, we move from theater to theater every day, different theaters. So it's not necessarily that you meet that person. But what usually happens is that when you're booked for surgery, the day before, we try to pass around the theater, pass around the wards, just to see who is scheduled for surgery, just to check up on you, and then just see that if there's any last-minute tests that need to be done or if there's any issues. So sometimes you see the patients beforehand. So that's for elective. With an emergency, it's practically impossible because the emergency patient is rushed in. So what happens is that you can't really do much. I'll just quickly see to you, try and find out what's going on, and that. But it's practically impossible to really, really get and see to you. So that's what happens.
I see. So basically, you are saying that patients and people, high listeners, you have a right to know the kind of or the type of anesthesia that will be used on you, or past is it maybe going to be gas, or injection? So doctor says you have the right to ask. So please develop that rapport with your team, your doctor that books you for the surgery, and ask questions. That's what doctor is saying. He's a senior anesthesiologist in Korle-Bu, and for him to tell us this, you should know that is your right. You have to know that. Okay, great. So doc, let's go on now with the CS. People say that as a woman, when you have your first baby through cesarean section, we are not going into gynae now because that's not your specialization, but you are the anesthesiologist. Is it true that because of the injections you people give us during CS, we are never the same again as women? They say that your back will continue to ache, your spine, if care is not taken, you won't walk again, you won't a whole lot of myths. I don't know. So doc, is it true?
Okay, so let me explain some little things. So when I was talking about anesthesia, I said that we have general anesthesia where your whole body is put to sleep, and then we have regional anesthesia where part of your body is numbed. So for a cesarean section, we go to cesarean section, we know about it. We try and take the baby out of the womb, but because the mother is not able to deliver from the vagina, you have to make a cut in your abdomen. Okay. Now, for a surgery like that, it's not really necessary to numb your whole body. Now, I'm moving my fingers here. You can see me moving my head. All of these things are controlled by nerves. And these nerves are all coming from what we call our spinal cord, if you remember that correctly. So our spinal cord is there. It's surrounded by some membrane, which I'll call the dura. And then
Okay.
Tissues are on top of it, and this is deep in your body. Now, what was realized is that if you can get a drug, which you call a local anesthetic, if you can get
Okay.
a drug and inject it in an area which is surrounding the spinal cord, you're able to block specific areas on the spinal cord, which
Okay.
block these nerves, which supply all that area connecting to your womb and your legs as well. And the surgeon is able to cut your body, cut your tummy, take out the baby safely, close up your womb, and put you back together without you feeling any pain at all. And with this method, which is very, very common, you are able to be awake. You will see your baby delivered. And what you are even practicing now is practicing as soon as the baby is delivered, you are able to see the baby, and we put the baby on your chest. That is what we call regional anesthesia. There's different ways of doing it, but the most common that you'll see is what we call the spinal. So with the spinal, what is happening is that these local anesthetic agents, which are going to block the nerves there, they're injected around your spinal cord, and they don't touch the spinal cord itself. It's just the area around, which is surrounded by fluids, which we call CSF.
Oh, okay.
And that's where the drug is placed. Yes. So the drug is placed. And that's what we call spinal anesthesia. Yes. But something
so
called
it doesn't touch the
epidural
spinal
anesthesia.
cord.
It does not touch the spinal cord at all.
I
what we're doing is that the area around.
Do you know that?
Take something like.
I mean, I don't think a lot of people know that.
Oh no! It's not touching the spinal cord. We're just putting some fluids around it, which are just blocking areas, but it is not touching the line. So to get to that area, we have to use a needle. We have to use a needle to get to that area, and that needle is the same needle that you use for small injection. When you're having an injection, or if they're taking a blood sample, they use a needle. I'm sure you've seen a green needle, very, very thin, tiny needle. And that needle, we use it to take blood samples. Or you see that them using that needle is if the doctor or the nurse is giving you an injection in your buttocks or in your thigh. It's that same needle that you see them using. Right. Now, the needle they use for those injections, we use a needle that's even smaller. Very, very thin. Very, very thin needle. So that needle, it just passed through your skin, through some tissues, past the bone, and into the area around your spinal cord. And it's a very, very thin needle. That needle is not likely to give you any serious pain because it's just like having a little needle prick. Or if when they check their sugar, that's the same needle. So that's what we do with a spinal. I'm saying spinal, but you must have heard about the term epidural. What's the difference? Yes, so we have epidural as well. And with the epidural, what happens is that we use this same local anesthetic, but we don't put it in the fluid around the spinal cord. We actually place it in the area which is above the tissue, which is called covering the spinal cord. And that's the epidural. Epi coming from the Greek word from above or around. So it's above that space. So we don't even go near the spinal cord. So even that one is even far away from the spinal cord. And with the epidural, the drug is placed around that area. And we are able to leave what we call a catheter. So we are able to leave, it's a little thin plastic drain. And the benefit of this epidural is that we can leave that drain in and be giving our drugs bit by bit. And it can be there for 2 to 3 to 5 days after your operation. So that you will not feel any pain at all because these drugs are there blocking these nerves. So that's the epidural. But this epidural is also good because it's not necessarily just used for cesarean section. You can also use it for when you're delivering your baby. Now, classically, you know, when you go and deliver, I'm not a woman, but it is a very, very painful process. Very, very painful. There are some drugs that the nurses can come to inject, which may help a bit, but it's actually a very, very painful process. So you can actually have the epidural placed in you, not just because you're having an operation, but if you're having a vaginal delivery. If you're having a vaginal delivery, we would put a little needle there at your back. You would set as well as normal, but what you would have is just a small injection at your back. We'll put this drug there, and it numbs the area just around the tummy. You'll be able to feel the contractions, but you will not feel the pain of it, and you're able to deliver your baby safely. And that is actually done worldwide, especially in the Western world. But it is not so common in Ghana, but it's now being more common. We had problems back in the past because not many people had access to these services, and we did not have many anesthesiologists as well. Because as I said, all these procedures that I'm telling you about, I may have described them to you, but there's always a risk of complications. Now, we always have to remember anesthesia has to be safe. You want anything that you do, it has to be safe for the patient. You want the patient to recover and there not to be any problems. But with these epidural and the spinal, sometimes we have some slight issues, which as an anesthesiologist, you must be aware of and be ready to jump in whenever it happens. So, and examples of that, sometimes the patient's blood pressure may drop a little bit. So we have to work on that. And then sometimes what may happen is that, not saying in most people, very, very few people, sometimes there's some people that may have allergic reaction to the drug. But as an anesthesiologist, it's not really a bother for us. We are able to jump in and solve those kinds of problems. So those are the little issues. So if you get a spinal anesthesia for a cesarean section, it is very, very, very unlikely that it's going to have a long-term effect on you. Now, I've been working for more than 15 years, and I do not have done so many cesarean sections and so many spinal anesthesias. I've not had a patient that's had a complication. Now, if all these procedures are done very well, it's very unlikely that anything that may happen. So it is not true. Sometimes you have some people telling you that, when they came to injection, I'm back for 5, 10 years, I still feel where they pricked me. It is absolutely impossible for you to still feel. Because as I said, the injection that you had is smaller than that you use for a needle. So it's a normal, so sometimes, but we know people have a phobia of needles. And patients were
definitely,
funny. You know, patients, anything that happens, they may attribute it to what happened. You know? And then sometimes too, someone may have a bad experience with their spinal anesthesia, because sometimes it may be difficult for them to locate the place where to inject the local. So when they do, and they have a bad experience, like, they don't want to go through it again, don't want to, But it's actually much, much better for the mothers to have this regional technique, because you are awake, you don't fall asleep, you hear your baby moaning, and the risk of complications is actually more reduced. However, I must say that there are some cases where the mother will have to be put to sleep. So that happens sometimes, because there may be some patients that may present with eclampsia. Eclampsia, a condition in which mothers have very, very high blood pressures, and they may have convulsions. And they may have convulsions that they're actually unconscious. Yes, this sometimes happens. This sometimes happens. Yeah, so the patient has come and the patient is unconscious, or the patient is drowsy. It's not safe to be doing a regional anesthesia in this person, because the person is not able to control their mouth or breathe. So if you go and give this technique and something happens, you're not able to control, you could have a problem there. And then sometimes there's some mothers, they have what we call placental abruptio. The placenta has removed from the womb, so there's bleeding there. Sometimes there may be some people coming in with bleeding, severe bleeding, coming from we don't know what's the cause. It's not safe. It's not safe to do a spinal in these patients. And then sometimes there's some patients, they may be at home, baby may have died, they may have had an infection, they never realized they had an infection, and they are in such a bad shape that you cannot do this regional technique in them. You have to put them to sleep. You have to put them to sleep, yes.
Wow. So, Doc, I mean, you've had you've worked for so many years, and you are a senior physician anesthesiologist. In the course of, okay, no, let me leave this question for when we are about to end.
Okay.
There's something we call embolism, right? Have you ever seen maybe someone who had a cesarean section and had such thing? Have you ever seen such?
Sometimes it happens, but with embolism, I don't know if you're talking about amniotic fluid embolism or pulmonary embolism. One of the things that we have to know about pulmonary embolism.
Okay.
Yes. So with embolism, as you're talking about, sometimes what happens is that you may have a clot, a clot either from the amniotic fluid, that's the amniotic fluid embolism, or we have a blood clot itself, which moves from the blood and goes to the lungs.
Yeah.
Now, something like this is not actually related to the cesarean section itself. Mothers too are pregnant. Yeah. So pregnant patients, as part of the changes that happen associated with pregnancy, their blood actually becomes very coagulable. So they have very risk of clot forming. Yes. Now this is increasing. Now, now with pregnancy, you get your legs swelling up. The person becomes pretty big.
Yeah.
So they're always at risk. They're always at risk of any of these things happening. So the risk of all those things are more related to the pregnancy itself than with the cesarean section. The cesarean section
than with the
yes.
thank you. Okay. I get it. So there's no relationship between
some patients. No, there's no relation. But what can happen is that the patient has had a cesarean section. They were very fine. You take them to what we call a recovery ward after operation. Then you see that probably 6 hours time or 3 hours time, patient is having difficulty breathing. So then things are running through your mind. What is going on? Yes.
Yeah,
and this can be because the clot has moved from the blood and has gone to the lungs and is blocking access for your lungs receiving oxygen. And that's what's happening, and that the patient is having difficulty breathing. So that's the embolism, but it's not directly related to the cesarean section. No. It's actually more of a risk of pregnancy. Yes.
Okay.
So that is a risk of pregnancy itself. Yes.
A risk of pregnancy. Okay. All right.
Yeah.
Thank you. And with the epidural, just like you're saying, that means there is no side effect whatsoever, and it even makes the delivery easier. It has a side effect. Does it have any side effect?
Oh, there are side effects of everything. I would say it's a clear.
Okay.
So every procedure there are complications. Just like if I cook jollof, it's not going to taste nice. Because that could be a complication. Nothing is really seriously perfect. Yes.
Okay.
So with the epidural, there's always risk with every procedure. That's why usually when you're being trained to these procedures, you are under supervision until you're able to do. Now with the epidural, as I said, we're putting a needle there in your back, yes. But sometimes there may be some problems that may happen. Sometimes it may not work. It happens sometimes. It may not work. Sometimes where we have gone and placed it is not the correct place.
It's not the correct
place. There's also a side effect of, yes. There's also side effects, which happens sometimes to some people, is that their blood pressure falls. But with that, we just give you fluids and there's some drugs that make your blood pressure go back up again. So these are some of the effects that may happen immediately. The other effects which happens much, much later, which some people complain about, is that they have a bit of a headache. Sometimes it happens that they have a headache. It happens. Yeah. I'm not saying all these things are common. It don't happen that often. Not with the cases I do. Once in a while, I have a patient that complains of a headache. But with this, you just let the patient drink a lot of water, or you let them lie down. They should just lie down. So that it goes away after some time as well. Then there's a risk of possible infection of the area. But I can tell you that with all these cases that cases I've done, I have not received any case because we try and make the procedure as sterile as possible. You clean with disinfect the area. You know, it's a very sterile procedure we try and do because you're going around the spinal cord. And as I said, there's a possible risk of damaging someone's nerve. But we are experienced. We have been doing this for a long time, so we haven't had any of these complications. But the textbook will tell you that you have a chance that 1 in 10,000 patients you may have something like that happening. But these procedures are relatively safe, done in safe hands. And the other thing that is that when you're doing these epidural or spinal, it should be done in the hospital. It's not something you do at home. It should be done in the hospital. The patient should be monitored. You have to monitor the patient. You have to be checking the patient's blood pressure. You have to be checking the patient's heart rate. Just making sure the patient is fine with what you're doing. Because you're introducing drugs to the system. Now, if you do all these things well, it should be fine. But epidural is not something anyone's going to do in the house or not. No, you're not going to do something like that.
Okay, Doc. So, are you trying to say that in this number of years of your work, for like 15 years, you've been doing this, you've not seen any case whereby maybe a doctor or anesthesiologist has been sanctioned for negligence? Have you seen anything like that? Maybe because
maybe
no. Have you seen any case of maybe in a CS and then maybe something went wrong and they felt it was the anesthesiologist that didn't do what he's supposed to do? Have you ever seen something like that?
Oh, cases have been have happened before because as I said, we're all human beings and you can't say that there's negligence. So negligence has occurred. So what usually happens is that any procedure that's done, there's documentation done. Anything that happens to is also looked at. Now, patients have previously gone and sued about things that they felt has happened and there was negligence or so and this. Yes. So the cases have happened like that. I personally have not been involved, but these things come out and they have come out in the media. They have come out in the media as well. And yes, these our practice is looked at, especially when you're dealing with a mother and a baby. People look at that. So these cases have come out before, and there have been media reports have come out about that.
All right, Doc. Someone says, Anita, ask Dr. Fred, how long does it take for a patient to recover fully? So Pearl is asking this. So how long does it take fully for a patient to recover? Pearl, I don't know. Is it from the CS?
Spinal.
Oh, okay. So maybe you just explain the three quickly, and then I go to the other comments.
All right. So if you have the spinal anesthesia, as I said, you put a local anesthetic agent, and this puts the area around your spinal cord. Now these drugs they don't last because they are metabolized or the body breaks down these substances, so they don't last for long. So usually for a spinal, we can change the duration of how long it lasts by the amounts that we give. So we can make it last 1 hour, we can make it last 2 hours, we can make it last 3 hours. Now for a cesarean section, which doesn't take that long, probably about 30 to 45 minutes, you just want a drug just to last for about an hour or an hour and a half or so. So within an hour and a half, what usually happens is that the patient, all the numbness that would have happened, the patient recovers from it. Sometimes the patient was not able to move their legs. They are able to recover from all those things. So within an hour to 2 hours, they're able to recover. Now, sometimes with the epidural, as I said, epidural, we can control how long you have it there because it's like epidural, we leave a little catheter inside and we can give the drug as long as you want. So basically, with withdrawal of the drug, you should be able to recover within 1 hour to 2 hours. It doesn't take that long at all. It doesn't take that long.
Okay, so within 1 hour, 2 hours, you should be able to
you'll be
recover.
recovered.
All
Yeah,
right,
you'll be
all right,
recovered.
okay.
Yeah.
You'll be recovered. All right. So yesterday from the comments when we posted this was that Ronke asked this question: what are kinds of epidural available, or is it just one type? What are the kinds of epidural available, or is it just
There are
one
types of
type?
epidural. I just want to get confused epidural and then the spinal anesthesia. The epidural is just one type
It's
because,
just one
as
type.
I said, the epidural is put in the space
Okay.
just above the. Yeah, it's just one type
It's
of
just one
epidural,
type.
but we
Okay.
can put it in different areas of the body. So this epidural,
Okay.
yes, this
Okay.
epidural that we're using for your baby being delivered is put in the lower part of your body, but we can actually put the high parts of your body. The surgeons are doing operations, not sections, maybe operating on the upper part of your body. Maybe they want to work on your stomach because of cancer, or they want to work on your liver or your gallbladder. Sometimes the surgery is done above that, or even operations for the breast. So what you do is that the epidural, as I said, you can block nerves, so you can place it a bit higher up the body, and you're able to block the nerves supplying either the breast or nerves supplying the stomach so that the surgeon can work. And we do that. We leave it there, and you are able to recover because there will be reduction of your pain for the next 3 or 4 days. Next 3 or 4 days after the operation. Yeah. So
Okay. Okay.
that's the epidural. Yeah. That's it.
That's epidural. So it's just one type, simple. Pearl was asking that. She says, I mean, after
Yeah,
the
it's just one time.
procedure, actually referring to the wound, how long? Okay, so Dr. Fred, can you give us how long the wound is? How long one recovers from the wound, or how long does the wound take to recover?
The
To heal
wound.
rather. Well, that you are not.
Well,
An urban guy, but
that's
I don't
more
know
for the
if you
obstetrician
can.
or gynecologist. Yeah.
So Pearl,
No, no.
he
So
is.
you see, for recovery, yeah, I'll talk. I say for recovery, I'm
Okay.
not sure. You say for us, what we want you to be is that you want to be up and mobile as soon as possible. So, but because of the wound that is there, sometimes you're not able to get up. So with the pain. Now, for
Yeah,
the wound to heal
exactly.
itself, that one is more for the obstetricians. I won't go and hazard a guess here because this is public
Okay.
and everyone is
All right.
watching.
All right.
I won't
All
give
right.
hazard a guess here. So that's more for obstetrician to say. Yeah.
Okay. Hilda was saying that she said, why is the spine the only place for anesthesia injection? I think you mentioned on that before, right? Is the spine the only
Yes.
place
So
for anesthesia injection? So it is that region that is. But you mentioned that it doesn't
that's what
touch
we do for
the
the
spinal
spinal. Yeah.
cord. You
No, it
said it.
doesn't. But if you're talking about
It
anesthesia
doesn't.
injections, we do what are called nerve blocks. We can block specific nerves. So that one, we don't
Okay.
even need to go round to the spinal. So we actually,
Mm.
we can block around your shoulder. We can block around your
Mm.
arm. We can even block around your neck, your lower leg too. So
Mm.
sometimes we inject in different places. And we're using the same local
Mm.
anesthesia agent. We can go and block specific nerves so that the surgeon can work around in those areas. And sometimes these blocks are also done for people who are in chronic pain, having pain which is so severe, which is not resolving.
Okay. Now, Sandra wrote a long comment here. She said, I had all 3 daughters through cesarean sections, 2 emergencies and 1 elective, just like you mentioned. And the first C-section, I was in labor, my water broke, but my baby was in distress, and I think she had to be operated upon. So 3 times had cesarean section, and she says she sees nothing wrong with it. My third, because of the previous incident, my consultant advised elective at 38 weeks. I think she's really done well. 3 CS. Then Dr. Gansa said, great topic. Okay, Benjamin was asking if the video will be available. The video will be available on Facebook and on YouTube when we are done. So I think these are the basic questions that we got. And okay, so that is that about the questions. Doc, is there any other thing you want us to know so that we wrap up?
Yeah, so just like someone was saying, there's nothing wrong with having a cesarean section. Now, all the obstetricians would prefer that you deliver vaginally. But no doctor is going to do a cesarean section for you unless it's what we call indicated. So there's reason for that cesarean section being done. So,
all right.
And if it's your first child and you have a cesarean section, does not necessarily mean that the next one will be a cesarean section. You may be able to deliver vaginally. But if a cesarean section is being done, it is there to save your life.
It is now, there to
that's
save
cultural things life. About to say, oh, you were too push to push and things like that. No. You don't have to worry about that. The ultimate aim is to make sure that you save the mother's life. And then with the baby, you know, as they always keep saying, who are you going to save? The mother may be able to get another baby again, even if the baby is lost. But with the mother, if you lose a mother, are you going to get the mother back again? No, you're not going to. So we always try and do everything here. And, you know, maternal mortality is a very, very big issue. No one should be pregnant and die.
Yeah, maternal mortality.
It shouldn't happen. It shouldn't happen. So the role that
I mean, for you to lose your baby, why not just go for the CS? You know? Yeah.
So sometimes you have to think that a patient, they're told that, oh, you have to have a cesarean section. And they're like, oh, I need to talk to my pastor. My pastor said that, that you will not have an operation, all that thing.
My pastor.
Think about yourself and say, yes. Think about those things. You don't want to go and lose yourself just because of this. So you have to make sure that we do the right thing. Whether you have a cesarean section and you have a scar, don't worry about it. As long as you are alive. So the role of the anesthesiologist is we need to make sure that everything goes fine for you to have that cesarean section. You shouldn't be bothered at all about what happened if you had to have an operation or not. Maybe some people they're worried about
it. People are bothered too about. Some are bothered about the big, their abdomen becomes big after the CS. Some don't recover fully. I mean, like, it doesn't go flat like previously, but some too have done it. I know a lot of people that have done that have had CS and have flat tummies anyway. But I think that depends more on individuals. I don't think it has anything to do with. Pearl says that one thing I have observed is education in this area still need more work, especially our health workers. They don't give us information on how to deal with the pain after. Secondly, how the patient can also deal with recovery is also lacking. Most patients are not educated enough on how to deal with themselves after a cesarean section, and sometimes it can draw you mentally. That is so true. Postnatal depression is there. I mean, that is true. So it can draw you mentally if you don't take care. And I mean, I think just like Doctor is saying, it's our religious beliefs as well. Some of the pastors are not helping as well. They will tell you that you have to deliver like the Hebrew woman and blah blah blah, all those kind of stuff. So I think all those things are not helping. But today, Doctor has really told us that there is nothing. In short, it doesn't even touch the spinal cord. It's just the area around the spinal cord, and that you would definitely recover after a few hours. But then we know that it is the human body, and so far there is a cut and there's a wound. Definitely, it's going to take some time to heal, but you are going to be fine. And as such, let us encourage our sisters, our wives, who maybe a doctor is telling that you may need to undergo surgery. Don't let us resort to the prayer camps or the churches and all that. Sometimes you have to do what you have to do, and then you back up with your prayer. it works as well. So because it is what you believe in, but don't let us solely just depend on the prayer, neglecting the medical aspect of it. If a doctor tells you a CS is important for you, is what he's going to have, and there's no option, then please and please accept. Please and please accept. Doctor, I'm very, very grateful for what you've done for us, educating us on anesthesia and during the cesarean section and the epidural, and allaying all our fears and telling us the truth about it. But Doc, one last thing I just want to know.
Yeah.
So aside cesarean sections, are there people that you've given a normal dose, maybe you normally give to that particular weight of person, and the person still didn't feel anything? Maybe the person didn't feel anything at all. Are there people like that? Because
It happens.
I heard that some people, they drink a lot, so those injections are not effective against us.
Yeah,
Is it
yeah,
true?
you're very right. Oh, it's
So
true.
tell us.
There are people like that. And then the people who are drug addicts, for instance. So sometimes you have some patients that, because they're taking a lot of alcohol, drugs don't work normally for them. And so you end up, because what happens is that their livers are something, and they break down the drugs you give them quickly. So sometimes we have to give some more to them. Then, but I'll tell you that we have the other extreme too. There are some people who we call, in quotation marks, innocent. They've never taken alcohol in their life. They haven't taken a drop or anything. So if you give them
Yeah.
a small amount of morphine, it totally knocks them out, because
Yeah.
they are pure. They are pure people. Yeah, it sort of happens like that.
Mhm.
So a person will be totally knocked out, and it will take them
Wow.
longer than usual for them to recover. Now we have drugs to counteract all these things. As you said, there are some people. Sometimes you even give to them, they refuse to sleep. So you have to go and use much higher. Culturally, we say that
Mm.
you have to go and ask permission from their ancestors or all those kind of things. But it's not really that. It's just that
Ah.
the human body is different. Everybody is different. What may work for one person
Mm.
doesn't work for another. Sometimes there's some patients,
Mm.
what
Mhm.
you're giving to them, the gas you're giving to them, they're not sleeping. So you just have to increase the
Mhm.
dose. Because we're all different. We're all different human beings,
Um.
different feelings. Yeah. So it happens.
Yeah.
It's not
I,
what
I've
you want
I've
to
seen.
store. And
Mm. Go on.
one
Sorry.
thing I would say too is that, yeah, one thing I would say too is that in terms of the gas that we give to make people
Okay.
sleep for operations,
Okay.
50 years later, we're still not sure how it works. But it works. But we're not sure how it works.
Wow. So you are not sure of how that
It
gas
works,
works.
but we don't know. No, we don't know how it works. We don't know how it works. There's been theories,
Wow.
there's been ideas. There's been theories and
I
ideas,
see.
but we still don't know. Yeah. But it works. As I said, most people go through operations and they come out normal. Yeah, in good times.
Um. So well, I think one of these days I'll have to call people and ask them the experiences when they were asleep. What did they see? What were they seeing? Because I, for one, what I once had that, and I think I was just like, it was as if maybe you just going around in space, as if you're in space and just going
Okay.
around. That was
Yeah, that
what I
depends on the
saw.
type of anesthesia you had. Yeah.
That is what I saw. So, but I don't know if a lot of people can recollect or recount or remember what they saw. I don't know. I don't know.
Yeah, it's
Okay,
some
and
patients, some people they don't actually sleep. Yeah.
they don't. Yeah, that's true. That's true.
So
That's
that's
true.
what they may
Eh,
have been given a sedative whilst they did the local anesthesia. Sometimes happens too. Yeah.
oh, okay, okay. And then I've seen when I was in Nigeria where I was working in a facility. There was this child who was brought in and was sedated, but the child, he did a small kid, like 5 years then, and the consultant was shocked anyway. Actually, that day, I think the procedure wasn't done. I think so, if I remember
Oh, okay.
clearly. Yeah. because he said, okay, you they should let the boy relax and eat and go back home and come back. And so, I mean, it's true. It's true. Okay. And doctor, you're an anesthesiologist as well. What about people? This is just by the way. What about people that pop sleeping pills? I mean, does it have any effect?
Effects on what?
Yeah,
Anesthesia?
like no, not it's not part of, but like they always pop in sleeping pills. It doesn't have any
Yeah,
effect on one later.
sleeping pills are supposed to be taken under supervision of a doctor. So if a doctor prescribes sleeping pills for you, it should just be for a short period. It shouldn't be for
It's,
self-medication.
it's,
There's the issue with self-medication because sedatives are actually very addictive. You know, after some time, you realize that you can't sleep unless you take those sleeping pills.
Unless you take it.
Yeah, so it can be addictive too. Now, the problem is if you take too much or you take an overdose, you'll not be able to breathe. And then there may be complications. And if something happens, someone gets an overdose of sleeping pills. Or you leave it around the house and then a child takes it and pops one in the mouth. That's also the danger too. The sleeping pills are supposed to be taken under supervision of a doctor. Yeah.
All right. So let us not take any sleeping pills without the prescription of a doctor and
no, you need a prescription.
without.
You need a prescription.
Yes, yeah. Thank you very much, Dr. Osei, for being with us today. We are rounding off here. This video will be available on YouTube and I'll post the link. I'm very, very grateful. I mean, a senior anesthesiologist giving us his holiday time today isn't something to joke with because you're a very busy person. Yeah. So,
senior specialist anesthesiologist, actually.
Okay, senior specialist.
Senior
you see,
specialist anesthesiologist. Yeah, it's a mouthful.
All right, Doc. Actually, you are. I mean, respect. all right, Doc.
To you too.
So
you're doing well in your field.
So, Doc, we are going to end the live. Thanks everyone for joining in, for the comments, and I mean, whenever I come on, you people join in and contribute. I'm very grateful. I'm grateful for all what you did for me in 2021, and this year again. Let's do it together, and hopefully we are going to see 2023 by His grace. So we are wrapping up here, and Doctor, you just stay on and I'll meet you in the studio. Thank you very much, everyone.